This is Julie. I'm the Practice Director for Provincial Speech Language Pathology. Happy to be here.
Really would like to thank everyone for participating today. We're thrilled to have representation from across every zone with over 180 people participating today. And before we get started, I'd just like to make mention that this presentation is being recorded in video format by AHS. The recording may be used and disclosed by AHS for educational purposes and may be further broadcast by AHS for other presentations, publications, or promotions. This may include conversion to digital format, storing and publication on AHS webcasting technology. And today, the focus really is to orient you to the innovation learning collaborative methodology that each of your teams will be using to implement the new PEAS clinical practice guide and tools. This is the first session in a series of quality improvement workshops. Today's session is really foundational to moving forward together. You will not only learn about ILCs and quality improvement, but each team will also come away with a personalized team charter. These charters will be a living document to foster collaborative practice within and outside of your team, which is critical to delivering high quality, family-centered care, especially in the area of pediatric eating, feeding, and swallowing. Now, just a few housekeeping items. First, can you take a moment to look at the controls that are available to you? And please be sure to mute your microphone when you're not speaking. If you have comments or questions during the presentation, we welcome you to write them into the chat box. When it's time to go into the breakout rooms with your team, you will be prompted with a selection of available rooms to join at that time. We'll get into that in the latter half of the workshop today. Now, my favorite part. Before we dive into today's session, we wanted to start with a mindfulness moment. We know that everyone has so much going on, and with this being in a virtual meeting, it can be much easier to get distracted. Given that we're focused on pediatrics, we thought we'd share a quote from a wise old bear and his friend. "What day is it?" asked Pooh. "It's today," squeaked Piglet. "My favorite day," says Pooh. And that's certainly the feeling of many of us today in this very challenging environment. I think very exciting to have a day like today. So we really want to encourage you to be present so that you can fully contribute and engage in today's session. Take a moment to set aside any distractions and give yourself permission to truly be here together. You may want to turn off your cell phone and email. Perhaps jot down things that are cluttering your mind so that you can pick them back up later and not worry about them right now. Breathe, stretch and get comfortable. Think of a family that you have cared for that brings you inspiration and motivation for the work that we are doing today. And just ask that you would feel free to do this throughout the session. We have a lot of ground to cover in the next few hours. And most importantly, just want to remind you that AHS, your managers and leaders all support you being here today. They have made time for you to attend and agree that pediatric eating, feeding, and swallowing is an important priority. Now for today's session, I'll first just provide an overview of the PEAS, or actually I'm going to have Julie provide an overview of the PEAS project. Then we're going to hear from a family and healthcare provider. Tracy Wasilek will be orienting you to the ILC methodology. And then we'll have a chance to hear from an adult community rehabilitation team who has had great success with using the ILC methodology for another project. Then we'll take a 10-minute break and come back to work on your team charters in small groups and conclude by coming back together as a large group to share and learn from one another. We're excited to have a broad provincial representation from clinics and services in every zone across outpatient, community rehabilitation, and home care. As well, we are thrilled to have a number of family members who have joined us today that will be part of this process as family advisors. They will be joining us for the first half of today's workshop to get oriented to the ILC methodology, and then we'll drop off the call after the break. In the new year, we also hope to add stakeholders from primary care, public health, government ministries, and partners in social services and education to help each team round out their action plans as you consider the continuum of care. I pass it over to Julie now.
Thank you, Elaine. The Pediatric Eating and Swallowing Project, lovingly known as PEAS, is a provincial quality improvement initiative with the purpose of developing a clinical pathway to standardize and improve the care of children with pediatric feeding disorders. For this phase of the project, our target population are children in the ambulatory community care settings, so we've focused resources on outpatient and community care. That said, resources can certainly be applied and adapted to other care settings, such as acute care. PEAS is sponsored by the Maternal Newborn Child and Youth Strategic Clinical Network, and it's a grant-funded project with funding until fall 2022. This project began with 2 World Cafes conducted in both northern and southern Alberta, both in blizzard conditions. It was quite a memorable day with multiple stakeholders, including patients, families, SLPs, OTs, registered dietitians, nurses, pharmacists, social workers, administrators, amongst others. And I'm sure that many of you were there. In that meeting, people outlined what was currently working and what was not working in the care of children. It's exciting to see, and particularly, I am sure for those of you who are also in the World Cafe, just to see what we've accomplished together and how far we've come. These are some examples of quotes from the World Cafe, of key issues concerning families and care providers. And these really focused around lack of role clarity, communication concerns, access to services, gaps in knowledge, need to improve collaborative goal setting, and need to improve our provision of patient and family-centered care. Major themes that were identified at the World Cafes and are shown here, and these were similar in their frequency across the entire province, regardless of whether people lived in urban or rural settings, north or south. And I'd like to highlight that next to access to services and information, the second biggest barrier to high quality care for children with pediatric feeding disorder was a lack of role clarity and collaborative practice. And this is why we think it's critically important and foundational to be gathering here today to provide teams with the opportunity to work on team charters and to focus on their communication and collaboration. Using the World Cafe feedback, the project team applied the theoretical domains framework to develop implementation strategies to address major barriers in access and navigation, standardized practice and education, equipment and supplies, and roles and implementation. And that's what we're going to focus on today, really to target quality improvement using evidence-based practices in all 4 of these areas. I'm really excited, happy to every time I have a chance to show that this work has culminated in the development of a website as a one-stop shop resource for families and healthcare providers. The website can be found at peas.ahs.ca, and I have to say it's absolutely fabulous. We also provided 1-hour training sessions this past summer and fall to introduce the new tools, the clinical practice guide, the collaborative practice supports, some of which we'll be using today. These sessions have all been recorded and can be found on the PEAS website under courses and webinars in the providers section. Here's a quick snapshot of the timelines, and this brings us to today, the little blue flag in the middle of the implementation phases of the project, and a time today to focus on quality improvement using the innovation learning collaborative methodology, which Tracy will be walking through with you later on in the agenda. Coming up quick. Now, it's my absolute honor to introduce to you Deanna and Nancy. So throughout the PEAS project, the voices and stories of families and frontline care providers have been essential to ensuring that we provide helpful tools and that we make a real difference with our efforts. At every meeting, we invite a family or care provider to speak to us about their experiences and ask them to share their successes and challenges and advice about how we can improve. These stories help us to ground and remember why we're all here today. And today we're pleased to have both a parent and a provider. Deanna Stringa is a mom of a child with a pediatric feeding disorder, and she lives in rural Alberta. One of her care providers, speech language pathologist Nancy Whalen, is here and together they'll tell their joint story. I'd like to thank both of you in advance for your transparency and your desire to share. I know that you're doing this in hopes that you will inspire us all and give us courage to speak about our own experiences when you talk in your small, and encourage all of you when you're talking in your small groups to be brave as Nancy and Deanna are. We're going to talk about our core values as they do and what's working well, what isn't, and how we're going to get there. So this is really a call, I think, to be courageous in challenging ourselves and one another and creating a shared vision of success for your teams. And so really thank you again, Deanna and Nancy, for helping us to start to think through that vision. I'll pass it to you now.
So I'm just going to play a video that Deanna's actually created for us. And then she is also on the line. You can probably, you've seen her kind of pop up there on the screen. So, and then we'll pass it over to Nancy. So just let me know if for some reason you can't hear the video. You might have to turn it up a little bit, but I'm going to play it now.
Caitlin was born on August 25th of 2013. She is our middle child with an older sister and a younger brother. Caitlin suffers from cerebral palsy, secondary to hypoxic ischemic encephalopathy, and polymicrogyria. She has severe epilepsy, hypotonia, and global developmental delay. She is nonverbal, non-ambulatory, and she functions at infant level. Our medical journey started on the day Caitlin was born, and our feeding struggles started when she was 6 months old. I breastfed Caitlin right from birth, and the fact that she was able to latch and eat was a great sign and one relief, as we knew eating difficulties was a big possibility. At Caitlin's 6-month checkup with the pediatrician, it was determined that Caitlin was just not growing at a healthy rate. Caitlin was breastfed, so investigations started with my milk supply. It was astonishingly low. I was in denial that this content little girl was not eating enough, but the facts were there. How did I miss this? How did I not know? I was starving my child and I was oblivious. Caitlin was on seizure medications that were having a sedative effect on her. So she would eat, but she wasn't demanding enough calories to properly grow. An NG tube was the new normal for feeding Caitlin as we continued to try unsuccessfully to get her to take a bottle. Over the next few months, we tried everything from bottles, sippy cups, open cup, cereals, and solid foods. We had our first referral to the feeding team, and we were followed quite closely while we were in hospital. However, there was a huge disconnect between inpatient and outpatient services. Once we were discharged, we had to wait months before we would have another appointment with an SLP or any type of follow-up, and our subsequent admissions didn't always allow us access to inpatient supports. I continued with a few things that I had learned while we were in hospital, but mostly I just relied on mom experience and instinct. There was no plan or goal set for Caitlin at this time, as we didn't really have a clear team or contacts for support. Caitlin spent the better part of the next 6 months in hospital, undergoing testing and just working on getting her stable enough to live outside the hospital. Along with the feeding difficulties, we were facing several other medical challenges. Caitlin was having several status epilepticus events, putting incredible stress on her body, causing episodes of polyuria and severely dehydrating her body. By the time Caitlin is 1 year old, she undergoes surgery to have a G-tube and a chest IVAD inserted. The decision to insert the G-tube was out of medical necessity for possible life-sustaining fluid administration in the event of future status epilepticus events. We needed to be able to quickly replace the fluid loss that could happen from the polyuria. Caitlin ended up with a perforated bowel from the G-tube surgery. She was incredibly sick, and the recovery is very long. For 10 days, the sole nutrition for Caitlin comes through IV TPN, and it was weeks before she could tolerate full feeds again. When Caitlin can finally eat and drink again, she has no interest. Many attempts over the next weeks and months becomes exhausting. Caitlin had lost all interest in anything in or near her mouth, and all progress we had made with oral feeding was lost. Caitlin is diagnosed with oral aversion. Let me tell you, I was crushed. I wanted to give up. I didn't feel that proper supports were available for our situation, and I struggled with what to do. I couldn't take away the experiences that food and flavors could offer, so I persevered into unknown territory. At this time, our main support came from inpatient services. We didn't have consistency with team members, and even with our history charted, we were having to retell our story with each admission and each visit. It felt like we were reliving our failures over and over. I felt shame, and ultimately, I had a lot of negative feelings with oral therapy. I took every unsuccessful attempt as a failure upon myself. Fast forward to February of 2015. Caitlin is 18 months old. She suffers one of the worst status epilepticus episodes to date. Hours pass and the seizures don't stop. Caitlin crashes hard and her body begins to shut down. She goes into ventricular tachycardia and needs to be cardioverted. Caitlin is on a vast amount of life-sustaining supports and she is not expected to survive. I remember sitting at her bedside with the thoughts of planning her funeral, listening to every beep of the monitor, zoning out, watching the numbers, hoping and praying that something would change and show improvement, not knowing if we had seconds, minutes, or hours left before our little girl would leave us. Caitlin surprises the finest of doctors. Not only does she survive, but she recovers at an astounding pace. Caitlin will never be the same, and after all of these years, I still carry grief for the losses that we experienced. We were back to square one with not knowing if it was safe for Caitlin to eat orally. Her oral skills and secretion management were negatively affected. Her oral aversion was amplified. In March of 2015, Caitlin was started on the ketogenic diet for seizure control. That would add yet another challenge to oral feedings and offering taste. No sweets, no sugar, and instead high fats, oils, and creams, and no one with the experience or expertise that we needed to support us. Oral therapy had been put on the back burner. It wasn't a priority for the next several months or even year. We relocated to Vermilion in April of 2015, and with our admission to the home nutrition program in Edmonton, we were followed by a new team of specialists. By this time, it had been several months since Caitlin had any oral therapy, and we were essentially starting over. We lived 2 hours away from Edmonton, and appointments were few and far between. I had a lot of frustration with the regression, and I felt defeated at the lack of improvements. I lost the passion that I once had, and any oral therapy seemed like a difficult daily task that I did not want to tackle. Nobody checked in on us in regards to oral therapy, and because it was left up to me to follow up, it just didn't happen. I needed someone to take the reins and just tell me what options we had, what supports were available, and to make a plan for me to follow. I needed simplicity and I needed clarity. After getting our local supports in place, we were blessed with an amazing SLP that was eager to learn about Caitlin and for Caitlin. We finally had the consistency and support that we needed to make the next chapter in oral therapy a positive one. We were all in uncharted territory, but we never gave up on the idea that we might find something that was suitable for Caitlin. We tried many different concepts and explored many theories, but overall, we let Caitlin tell us what was right for her. This was the biggest lesson that I learned in the feeding journey. I had to let go of the idea that Caitlin needed to eat orally. I accepted that Caitlin is fed, she is nourished, she is happy and growing, and although it doesn't look how we ever thought it would, that's okay. Today, Caitlin is 7 years old. She is 100% G-tube fed, and she still has an oral aversion. Even brushing her teeth is a challenge. Caitlin still struggles with secretion management, and next month she is undergoing surgery to have her salivary glands clipped. Caitlin is an amazing teacher, and through our journey, I am richer in knowledge than I ever could have imagined. I love for people to learn from Caitlin and our experiences, and I am so grateful for this opportunity to share just a small part of our story. So thank you very much.
Wonderful. Thanks so much, Deanna. And Nancy, I'll just let you carry on with your side of the story too.
Sure. Can everybody hear me okay?
We can hear you. We
Okay,
can see
great.
you.
Great. I wanted to thank Deanna. That was an amazing story. And I think my favorite picture was Liam sharing his bottle. That was my favorite part. So my name is Nancy Whalen, and as Julie mentioned, I'm an SLP in Vermilion. And Caitlin and her family became a part of our local team in 2015 and stayed with us until she entered kindergarten in the fall of 2019. As Deanna explained, Caitlin had significant feeding and swallowing difficulties that required support that we were not able to provide or not equipped to provide by ourselves. So she ended up being a wonderful teacher for us. So she helped us learn as a team how important it was for us to consistently communicate with each other and ensure that our roles were defined. So sometimes we saw Caitlin together as a group, but oftentimes that was overwhelming for her. So the majority of our sessions were one-on-one, and we rotated through SLP, OT, and PT. And so it was crucial that our recommendations and our strategies were consistent and always related back to the plan that the family had to help develop. So we would often debrief, well, we would always debrief as a team after every visit so that we knew what was working and what wasn't working. So Caitlin taught me that interprofessional communication is truly fundamental for any therapist as a therapist, but also even more importantly for a rural therapist. There were countless times that I would say to Deanna, I don't know the answer to your question, or I'm not sure what our next steps are, but I do know somebody who does know. So I relied heavily on the expert teams in the city for almost every aspect of our intervention, from strategies and resources to ensuring that our goals and recommendations were appropriate for Caitlin. Navigating the system was sometimes difficult for me as a therapist, so I really empathize with those families that say that it is a difficult task to find who you need to talk to and when, because I found that hard. So it sometimes took time to find the right person to answer my questions. I always ended up where I needed to be. It just took more time than sometimes I was comfortable with. When I listen to Deanna's story, I'm reminded of the families that did participate in the World Cafe that we had talked about earlier. There were definitely similarities in the feelings expressed that day and today, frustration, uncertainty, hope, to name a few. I'm really excited to be a part of this ILC process. I think the end result is going to be system-wide improvements that will benefit not only our teams, but the families that we're working with that are navigating this world of complex feeding and swallowing. So the starting point in this journey is ensuring our teams are working well together so that we can begin to start making quality changes that are measurable and that we can be proud of. So thanks for including us in your discussion and sharing, letting us share our story.
Thank you so much, Deanna and Nancy, for sharing your story. Just so appreciate your courage and willingness to share your story. It truly is very inspirational. The persistence and resiliency you've demonstrated, and the tenacity to continue to find answers to the questions that you had related to Caitlin's care. So, thanks again.
Thank you very much again for the opportunity to share our story. I do appreciate it.
Excellent. Thank you. Oh, it's hard to move on after that, isn't it? So please, Tracy Wasluk is here today, and she is the Chief Program.
Sorry, Elaine, I was just going to mention, if you want, we have about 4 or 5 minutes if people have some questions too.
Oh, thank you so much, Vanessa.
Yeah, for sure.
Any questions for Deanna or Nancy?
I would just like to thank you so much for sharing your story with us. It's super meaningful to hear first-line experience and to hear from a parent, their perspective. So thank you so much.
I'm just curious, Nancy, how your team carved out that time. You said that it was really important for you guys to meet together to help coordinate care. Just curious to know, was that something you guys did formally, or was it just kind of on the fly?
No, it was something we absolutely had to do formally and make a joint effort in booking that ahead of time. So yeah, if we had a visit with Caitlin, we automatically threw in another 20 minutes to talk about how it went and what we need to do differently and what we need to change.
Nancy, it's Julia. I'm wondering about whether your opportunities in working with this family made changes in how your team works together in other situations.
Yeah, absolutely. It almost it really highlighted the importance of that, of talking to each other with those little ones that need multiple therapists involved and multiple people involved, and have more than one team for sure. So we have talked about it as a team, just in general around, so who do we need to support in this way, and what do we need to do? So it has absolutely generalized into most of our multi-D practice.
Just another example about how Caitlin is encouraging us all to learn, right?
That's exactly it.
Any other questions or comments? No, thanks again so much, Deanna and Nancy.
Thank you.
We'll now move on to, so pleased to welcome Tracy Wasluk. She is the Chief Program Officer with the Strategic Clinical Networks within Alberta Health Services. She has held numerous senior leadership roles within AHS and the previous Calgary Health Region. Tracy holds an adjunct assistant professor appointment with the Faculty of Nursing at the University of Calgary. Tracy received the Order of Merit Nursing Policy Award from the Canadian Nurses Association in March 2018, and she is also the recipient of the 2015 AHS President's Excellence Award in the category of innovation. Welcome, Tracy.
Thanks, Elaine, and welcome everybody. It's so nice to see so many familiar faces from the rehabilitation world that I've worked with in previous learning collaboratives and some of our SCN work and the rehab advice line. So nice to see you all again. I also want to just shout out to Nancy and Deanna. What a great story. Thank you guys for sharing it. It actually got me a little emotional, and maybe that's a good thing because it reminds us of why we're here and that the important connection that we have with Albertans. And Nancy and Deanna really showed that in spades. And so I think it really sets a nice tone for us. And when we think about their story, we also have to think about how do we help families and patients and their loved ones have a quality experience when they interact with our health system. And this slide, the first slide, just is a reminder to you that everyone's quality is always our business. I know you know that, but it's good to be reminded of it. It doesn't stop. Even when we make improvements, we know we can continue to do better because every patient, every family has a bit of a unique story. That means we have to sort of adapt our capabilities to the individual needs. And everyone's perspective is slightly different. And so for today and throughout this learning collaborative, I hope that you, as Elaine said, from a mindfulness perspective, sort of put your feet up and think about the different perspectives as you move through this process. Because at the end of the day, empathy is created through understanding perspective. And quality is enhanced when we understand the different perspectives that we bring to the table when we're trying to improve the care that we deliver. Next slide, please. So I'm going to talk today, and this is going to be a unique experience, you guys. We're always learning. Here's another perspective. We're always learning and trying new things. And I will say that in previous, in our history, when we did an ILC, we did it in person. We had all of you in the same room. And it created a very different environment for us. But in the spirit of the pandemic, we're testing out new methods and new approaches. And so what would typically be done in an ILC is we're going to break it up into bite-sized chunks for you, and hope that the way that we approach doing it virtually still creates the passion, the enthusiasm, and the desire to build a quality system in this area and think about how we can deliver better care and improve our capabilities as providers and as a health system. So my job today is really to talk a little bit about the first phase of this. How do you build a quality system? And more importantly, how do we bake quality into your practice in a meaningful way? And this comes from Health Catalyst. I don't know where I lost my my reference, but Health Catalyst has done a lot of work through within the Intermountain Health arena, and they talk about three major things. We need evidence-based practice. We need analytics and ways to measure that practice. And then we have methods, improvement methods, so that we can take the evidence and the measurement and continuously improve on our performance. Next slide. So one of the first things you have to do, if quality is your business, then you have to have a definition of quality. And in the SCNs and in Alberta, we've adopted the Health Quality Council's definition of quality because it has 6 dimensions to it. Lots of people, when they think about quality, they often think about just access and safety, but we actually know there are many dimensions, and it's important to us from a perspective, a different perspective, to think about all of those dimensions as I've outlined them. Next slide. I want to talk a little bit about evidence. Evidence-based practice, it's constantly changing on us. We know that we can't keep up with the science and the evolution of information and advancement, but there are ways for us to think about bringing evidence into practice and using our techniques as a health system to do it thoughtfully and do it well. Next slide. So in the SCMs and obviously in Alberta Health Services, we believe to be a high-performing learning system, we have to do 3 things. We have to apply evidence, we have to share it, In many cases, we actually have to create it. And through this ILC, you're going to be doing all three of these things. Next slide. But in some areas, I also want to remind people that in some areas, we actually don't have the evidence. We're still trying to garner it. And in absence of evidence, there actually is evidence. And that tends to come from your individual clinical experience and expertise. As you see clients and you see patterns in some of the work that you're doing, you're actually generating a bit of an evidence base. The second big pocket of evidence is the lived experience of patients and their values and expectations. And when I heard from Deanna, I thought she's got a rich evidence base around her own daughter, but also their family experience and their interactions with the health system. And that is a really critical part of our evidence understanding. And Nancy, I think one of the things that Deanna said is you took the time to understand them as a family. And in some ways, that's your way of understanding the evidence base, the values and the expectations from their perspective. And then finally, we know that there's the published evidence in the literature, and there's a wealth of it. Next slide. So the final piece, or the second piece to this, is analytics. And analytics is more than just counting things. It's trying to, next slide, it's trying to think about how do we measure things of relevance to us that allow us to make changes in the way we deliver care to the betterment of Albertans. And so measurement and analytics come together to help us customize our strategies, incent change, and then demonstrate the changes that we've made and make it relevant to our clinical environment and for patients and families. And so in a measurement system, we have to think about incentives for change, we have to think about indicators for change, and we have to think about benchmarks and what are the changes that we are all going to aspire to get to. And those benchmarks can be local, they can be provincial, or they can even be world's best standards. And one of the ways that we help bring a measurement system together and make it real is thinking about key performance indicators that will help us achieve the success and the goals that we've set down for ourselves. Next slide. So one of the challenges if you don't have good analytics is you get this, and in many of you will have been in conversations where someone's opinion trumps the evidence, maybe because of their position in the organization, maybe because their position on a team. But what we're trying to do by building robust measurement and analytics is to prevent the hippo from trumping what we think is the right thing to do. Next slide. So when we think about a framework, I'm not going to get into too much about this, but today you're going to talk about what your goals are with PEAS. And that's really establishing your charter, your mission. What is it that you're wanting to accomplish? And through that process, you will think of some goals and objectives. And inherently what comes out of that is then, well, what are some of the targets? If these are our goals, what targets are we going to choose to know that we got there? And once you get to that point in your journey, you're going to think, well, can I measure that? Or where can I get the measures in order to let me know that I'm moving towards my target, that's helping me achieve my objective, my goals are being achieved, and our mission, or raison d'etre, which is improved outcomes for families and patients, is being met. Next slide. So goals of measurement, I just quickly want to talk. Sometimes people get a little mixed up about the goals of measurement and the differences and similarities between when you're doing research and when you're doing quality improvement work. And the fact of the matter is that quality is really a continuum. And in research, we tend to have a lot of rigor, and we tend to blind certain variables so that we can get the most rigorous outcome available. We try and design our tests of change to eliminate bias. And we have a hypothesis as to what we hope to accomplish. Once we achieve those objectives, we then want to spread those findings to other environments, because if it worked in one area, the question is, will it work in another? And that's when we tend to move out of the research measurement realm and into the quality improvement realm, because we're trying to take the evidence that's been proven and apply it in a measurable sequential way to multiple areas and opportunities. And so we use slightly different methods to be able to do that. But it's really two sides of a coin. Next slide. And so the other danger in measurement, and we often see this in the research world, is, well, let's collect as much information as possible so we can make sense of it. The challenge is, as busy clinicians, you don't have time to look at thousands and thousands of elements. So our goal in teaching you some methods over the course of the next year is, how can I focus my measurement strategy so that I can finish and also know that I have achieved the objectives. Next slide. And so we talk about building key performance measures or key composite measures. And this is just an example of how we go about doing that. And the team here behind the scenes has already started to help build this out for you. But really, you have to have a definition of quality, and you have to know what indicators that you're trying to look at. Are you looking at a safety indicator? Are you looking at an access indicator, an appropriateness indicator? And once you know that, you can start to drill down into thinking about, well, what are the indicators that I am interested in? Am I interested in a percentage of risk? Am I interested in a percentage of people that get a certain intervention? Am I interested in a certain outcome? And when I get that indicator, then I can say, well, how will I know that? And then you have to start thinking about, well, where would that data come from? Would it come from our DAD data? Would it be a manual chart review? Is it billing data? Is it physician clinic data? Is it patient reported outcome or experience measurements that we would draw from? And when you will be doing this over the course of the next year. And so it's really thoughtful for you, today's work, it's thoughtful for you to understand how all this is going to come together. Next slide. And so when we think about, the other thing that we think about, and I really heard this in the story today, was the journey for patients is across a continuum. It's not a static moment in time. Yes, there are moments in time where interventions occur, but we need to think about our measurement systems and our ability to improve care as we think about it from what we call a complex chronic pathway, where it's really everything from self-care to end-of-life care. And the reason that's important is, depending on what your goals and objectives are, you may need to pull upon data and elements that cross these various different sectors. And therefore, if you understand the journey, you're going to be able to select the measures of relevance so that you can build a more comprehensive understanding of, are you making an improvement or not? So I just want to flip to the next slide. So if we were thinking about, are we, for example, most of our care actually happens in the medical home with our providers in the community. And in this case, that's really relevant for you, for the population that you're serving. So you want to be thinking about your pathway development and your opportunities to improve care, improve transitions, and improve communication by thinking across, not just within. So it's a bit of both. And then once you do that, we can start to think about, well, what measures would we want to look at? And then that helps you focus on, are we looking at a particular population? Are we looking at a particular step in the journey? Are we thinking about outcome measures, process measures, cost measures? And again, putting together this comprehensive plan will really help you in your work say, wow, we're making a difference, or, oh, we're not making a difference, and if not, why not? Next slide. So finally, the key performance indicators. So this takes a lot of work because you have to define them, you have to know where the data comes from. And so Vanessa and her team have actually been working behind the scenes already to help really fast track this work. And so you can see on the left-hand corner of this slide, there's the quality dimensions that we talk about, which is the 6 dimensions. And then the P's performance indicators that have been generated through your World Cafes and all of the conversations and activities that have gone on before today that we're building up for today, we have pulled these together as a starting point for you and your teams. And I'm not going to read through them. You'll see the slides at another time, but you can see that each of these indicators is reflective of the dimension of quality that you and your team may be interested in. Next slide. So finally, some improvement measures, and I'm just about ready to wrap up. That's next slide, Vanessa, please. That is what we call the Breakthrough series, or the Learning Collaborative. And the Institute for Healthcare Improvement has developed this methodology years ago, and many of you on the call might actually have been involved in an ILC before in your previous work or through your previous regions. I know in Alberta we've been using these methods for a significant period of time, and we use them because they're built to work with frontline teams, creating a quality strategy that's relevant and important to them, and then having the support of some facilitation and quality improvement expertise to work through the problems that you're trying to solve, and set yourself on a course for building capacity on how do you do quality day to day, how can you learn about doing it better, and then how can you learn from your colleagues across the province as to how they're applying tools and methods to have an impact. So today we're in this pink area where we're really trying to set up a lot of the framework from which is kind of like the springboard for you to jump into action and start to complete changes in your practices so that you can impact your goals and objectives. But you can see, generally speaking, this is done over a 1-year period, so change doesn't happen overnight. And over the course of the next several months, we'll be moving through the orange phases and supporting you in your journey. Next slide. So the one thing I want to say that creates the success for an innovation learning collaborative is you need clinician-led teams. It has to be bottom up, because the people at the front lines deliver that care every day. They know what's working, they know what's not. And so it's really important that your team, and some of your team are here today and some of them aren't, but it's really important that you have everybody on the team as part of the journey. The other thing that we like about this method is it's a progressive approximation. It's not just a webinar today and then throw you into the field and good luck. It's we work with you over a period of time. We work on local improvements that are relevant to you in your clinical areas, and we hope that through the virtue of all of you as teams working together, that we can start to penetrate the change in outcome across the entire system. Next slide. We talk about 4 F's. I'm sure all of you love that F word. I know I do. And we really talk about those being foundational to the work. First of all is frontline and family engagement. And we really endorse having patients and families as part of your team, because they know what the lived experience is like, and they can provide a huge amount of value to the work that you're about to embark on. We like to focus on quality because we know if we improve quality, we know that we're a learning system, and more importantly, it takes care of a lot of our financial systems. We can't do this work without good feedback mechanisms, And a lot of projects struggle with finish. So our emphasis is we're going to focus and finish. And it's why we're going to, in some of our techniques, really be cautious about how big your innovations are, how much you're undertaking at any given time across this process. So engaging frontline teams, measuring progress helps us change complex environments. Next slide. We do use a method called the Balanced Scorecard. We're not going to talk about it today, but the team that's coming on after me, they're going to be speaking about this. And in a future session, we're going to get into the nitty-gritty. Next slide. This is what a scorecard looks like. It's got the 6 dimensions of quality across the top, and it helps us to give a bit of a measurement framework in those blue and red boxes so that you can set a baseline for where you're starting from. You can set a benchmark to where you want to get to, and then we can monitor your progress in between. Next slide. One of the things that we're really conscientious, and you'll hear about this when you hear from the team, and you'll hear it from us over the course of the next year, is, you know, we have limited resources. There's lots of operational realities that you're facing, and there are competing priorities. So the balanced scorecard helps us focus our attention on measures of relevance, of importance, and not too many of them so that we don't get lost. Next slide. And it also gives us the chance to select measures that are easy to measure, simple to understand, and they give us a chance to be smart in our process so we can learn how to do this well. Next slide. Next. And they help us balance unintended consequences. And many of you will have heard this in your clinical practices in the past, where somebody says, well, let's drop length of stay. And a typical clinician concern would be, yeah, but if we send them out too soon, they're just going to rebound back. So in managing a scorecard, what you're allowed to do is build indicators that we call balancing measures, so that if you have an intervention that is going to reduce a length of stay, the balancing measure would be that we would also monitor readmission rates. If you have a measure around communication, then we would want a balancing measure around prems and proms, so that we make sure that our communication is actually effective and it's achieving the outcome that it had. Next slide. So here's an example of the Pediatric Eating and Swallowing Provincial Project. The team has started to think about this already. I'm not going to go into this because we're going to have a complete session on that, but I wanted you to see a completed scorecard, because the team that's had this experience is going to be talking about their scorecard, and I just wanted to orientate it for you so that you could see that this is a way of focusing your attention on indicators of relevance, and over the course of the next year, learning quality improvement techniques to achieve the objectives you set out for yourself. So that, in a nutshell, is really what an ILC is all about. It's our opportunity to work with you, to build your capacity, and in the process of doing that, strengthen your team, strengthen the teams across the province, and create a learning health system that achieves the outcomes that we want to achieve for our patients and families in Alberta. Vanessa, I think I'm 1 minute off.
You're doing amazing. Thanks, Tracy.
So with that, I just want to say good luck. I look forward to working with you guys throughout the course of the next year. And I think, Vanessa, you're going to turn it over for...
We have about 5 minutes for questions for you, and then we'll turn it over to Elaine, to introduce Shane.
Okay. Does anyone have any questions? Does this make sense to people? I know you're all shy going, I'm not going to ask a stupid question, so that's okay. I think you can buy a bit of time on the schedule, Vanessa. And again, thanks you guys. And if something comes up, you'll have the slides, but if something comes up, you have a question afterwards, or in the course of the afternoon, some questions come up, either throw them in the chat box or send them to Vanessa and she'll get them to me.
Thanks so much, Tracy. Great overview of work yet to come, so super. We'll move on now to introducing Shane, and Shane Burnt is the Manager for Occupational Therapy, Stroke, Early Supported Discharge, and Home Rehabilitation Team in the eastern half of the South Zone. She graduated from the University of Alberta in 1995 and formed the OT department in Lac La Biche in her first position. After spending 8 years in the North Zone, she moved to the OT medicine clinical lead position at the Foothills Medical Center for 4 years. In 2007, she moved to Medicine Hat, where she has worked in acute care, outpatients, and community settings, including the team lead position for the stroke, early supported discharge, and home rehabilitation teams prior to becoming a manager. She has a passion for collaborative practice and quality improvement specific to patient and family-centered care. Welcome, Shane.
Good afternoon, and thank you. So over the past 6 years, I've had the good fortune to be involved in 2 Alberta Health Services initiatives that utilized innovation learning collaboratives. My first ILC was in 2014 as a member of the Stroke Early Supportive Discharge team, and an ILC that was organized by the Cardiovascular Heart and Stroke Strategic Clinical Network. It was the ESD staff who later dreamed of the expansion of their model of care and eventually led to the creation of the team that I'm going to introduce you to today for my most recent experience with an ILC. I hope to paint a picture of ILCs as an amazing race and inspire each of your teams to embrace this concept. For those of you unfamiliar with the reality TV series, The Amazing Race, it pits 11 to 12 teams against one another to win a cash prize. In order to win, they must be the first team to reach the finish line following the completion of travel across various parts of the world and fulfillment of challenges along the way, despite orchestrated and sometimes unforeseen barriers and facilitators along their journey. Based upon my experience with ILCs, I am confident each of your teams will find your journey to be just as amazing, but unfortunately without the $1 million cash prize. Next slide. So an innovation learning collaborative is a method of disseminating information and concepts to a large audience. Often this information is best practice learnings that needs to be absorbed and transformed within that audience. It has been used by many industries from education to business to healthcare. ILCs facilitate individual group learnings of key concepts through activities which can then be used to further expand the larger groups working, understanding through sharing of results of activities, both process and outcomes. Key concepts are then solidified for all regarding this new learning. As individuals or teams begin to trust in the ILC process and openly share their challenges and successes with one another, quality improvement begins at the same time these relationships are built, creating huge potential for networking outside the ILC and ultimately the ability to brag and steal one another's concepts or processes by replacing competition with collaboration. Next slide. So as with any process, there are rules of engagement. In the Amazing Race television series, this is consistently reinforced with every new route information card presented to the teams at the start or end of each leg or new location of the race. Teams are given clues of where they'll be going and how they will get there. This will be similar for all of you today and going forward for future PEAS ILCs. I encourage you to read the route information carefully so that you can build your own understanding of the information. Then follow through on all components outlined on your route card with your individual teams, but also reach out to build relationships with other teams or alliances and actively listen to other teams as they present to you throughout your days. These same alliances may offer you a fast forward or an advancement in your knowledge or methods of implementation. A fast forward can be as simple as your team gaining a better understanding of the client and family perspective to learning a quicker method of data collection for your local team that worked well for another team. Sometimes a fast forward can help your team to minimize or even avoid a potential roadblock detour, speed bump, or U-turn as you implement your PEAS model in each of your communities. Next slide. So my most recent experience with an ILC was in 2017. Our pilot, the home rehabilitation team, was launched in the South Zone during the initial call out for teams under the redesigned Alberta Health Services community rehabilitation model. Next slide. So the home rehabilitation teams, or HRT, in Medicine Hat and Lethbridge consist of occupational therapy, physiotherapy, therapeutic recreation, social work, and nursing, as well as our therapy assistants that work within a transdisciplinary model of care for a multitude of diagnoses requiring intensive team-based rehabilitation. It was created from existing community resources in the South Zone, meaning there was no new funding to build it. Next slide. So once we were accepted as a pilot into the community rehabilitation framework, the work truly began at both a local and an ILC level. Prior to our first ILC event, we began building HRT in both cities concurrently. We worked together to create a common name, referral form, and program criteria, but locally, we each created our own vision and mission, team processes, and marketing plans, as each site did have different composition in the way of full-time equivalencies. These same differences also led to slightly different rehab intensity and criteria. So Medicine Hat would accept clients who would take between 3 and 5 days of therapy per week, while Lethbridge limited their clients to only those accepting of 5 days per week. Both teams locally completed their own training and preparation for service provision in the transdisciplinary model, health change methodology, and the use of the Canadian Occupational Performance measure. At our initial ILC, we learned our route information for the community rehab model framework and the expectations for certain outcome measures, data collection, and scorecarding for all teams. We developed a working understanding of the EQ, 5D, 5L, and the WAD-LX, and what client goal setting and warm handoffs truly look like from the client's perspective. The ILCs allowed us to meet other teams trying to comprehend these same principles and concepts, and activities at every ILC assisted us to talk through our common ground and analyze and problem solve together. Next slide. So at subsequent ILC events and online follow-up sessions, we refined our learnings. We learned that other teams, like us, were struggling with the presentation of the EQ 5D, 5L, both at admission and discharge from the program. We were able to adapt our client scripts for this outcome measure based upon the larger group sharing. Participation in the ILCs also helped the HRT staff to embrace quality improvement as they sought out feedback each month from their scorecard results. Team discussions ensued on how to utilize the data collected to make changes to our ways of doing things. Next slide. So this is the first home rehabilitation team scorecard for both cities. The 3 yellow columns are the mandatory measures for all teams in that first rollout of the community rehabilitation model. The 2 red arrows are pointing to an accessibility dimension that is measuring wait time, which we established despite there being no literature evidence for the very diagnoses that the HRT team rehabilitates. And the other arrow points to a safety dimension around warm handoffs. So it actually is measuring the percentage of clients that were discharged using that concept. Next slide. So this is our current Medicine Hat HRT scorecard. It's an example of a detour. After the first 6 months in operation, both HRT teams removed those 2 red arrowed dimensions based upon the data collection and analysis. Each team had created operational processes that consistently put in place the warm handoff method of transition for clients and were consistently seeing clients within 5 days of receipt of referral. Because of this, we saw no need to continue to collect data or measure these dimensions as we were consistently hitting our targets. So in Medicine Hat, we added a new appropriateness dimension, which we call the program completion. So we were measuring how many clients stayed with the program right from receipt of referrals to transition off. Next slide. So outcome measure collection during our team development is an example of a speed bump. As the initiatives under the community rehab redesign evolved, access to technology for the EQ5D5L and the WAD-LX became available to all teams. We were given iPads for clients to complete these measures on and to reduce the overall demand for data collection locally and compilation provincially. The problem was that the majority of our clients were seniors and are less technologically savvy, so the iPads actually created a speed bump. After a trial period with the technology, we devised an alternate method of collection whereby paper outcome measures were still employed as requested by each client, but then later inputted by clerical or therapy assistants into the iPad. By accepting this alternative, HRT was able to sustain greater qualitative feedback in the comments section of the WAD-LX from their clients while preserving the lessened demand provincially for the compilation of all the results. Next slide. So as I mentioned previously, the two HRT teams started out with slightly different rehabilitation intensities due to their varied full-time equivalencies. So Lethbridge, I can remind you, was only seeing people who required 5 days per week of therapy, Medicine Hat accepting 3 to 5 days of therapy per week. So this is an example of a U-turn in your amazing ILC race and how it can actually be a positive. We were able to use these differences between our two teams to compare and contrast the intensity data with our other outcome measures. Our instincts suggested that clients on 3 days of therapy per week were just as successful as those on a 5-day per week plan. And more importantly, clients seemed to be more accepting of 3 days of therapy. We already knew there was nothing readily available in the literature for our varied diagnosis and aged clientele. So we analyzed the data that we had on the Medicine Hat scorecard because there was a large sampling of clients who had 3, 4, and 5 times per week of therapy that had now had transitioned off the program. So correlations were calculated amongst our outcomes. On the left is the correlation between visits per week and our clients' changes in the COPM performance. The correlation being negatively correlated at 0.022, or revealing no apparent correlation, while the chart on your right graphs the correlation between visits per week and the change in the EQ5D5L visual analog scale. Again, correlation not readily apparent at positive 0.139. But when we pulled the data and the correlations out specifically for each therapy frequency, there was a more significant correlation, specifically in the 5-day per week therapy category, or those receiving a greater number of minutes of therapy overall. There was a moderate negative correlation of 0.57 with the EQ5D5L, which actually means that the more minutes of therapy or the greater number of days of therapy, the less likely the client was to identify a clinically significant improvement in their quality of life. Next slide. So although innovation learning collaboratives have a lot of positives or benefits to group knowledge, integration, and collaboration, we also experience some challenges along the way. So HRT staff tended to be quite introverted within the ILC events, so they struggled to network beyond the activities required of them to join other teams. They also struggled as they found that they had few commonalities with other teams present. So HRT was a program offering intense rehabilitation, while other teams in attendance were strictly offering a particular group education or therapeutic intervention. All the teams did have in common the community rehabilitation guidelines, data collection, outcome measures, and mandatory dimensions on their scorecards. At the time, ILCs were only offered in person. and that happened to be in Leduc, a central location within Alberta. And so that added travel expense, which only permitted half of our team to attend, which reduced the HRT rehab intensity with their clients back home. Those team members in attendance were then tasked to bring back all their learnings to teach and build understanding with those not at that particular ILC to ensure follow through on process changes to accommodate those new learnings or expectations. Next slide. So I hope that you'll embrace your innovation learning collaboratives as an amazing race for each of your teams. These events can significantly impact the successful implementation of not only the model requested of your teams, but also spread the access of your services across Alberta for your clients and their families. Embracing these learnings along with a quality improvement mindset can help us continuously fine-tune our operations and therefore create efficiencies so that the true winner of this amazing race is each of our communities. And thank you.
Thank you, Shane. Before I thank you formally, we have about 4 or 5 minutes. If anyone has any questions for Shane, I'm sure she'd be happy to answer them.
It's the league from the North Zone. I just want to mention that, of course, coming from a rural zone, I can appreciate, you know, the face-to-face ILCs and the positive of it. But I'm so thankful that we could do this virtually, and I'm really excited to see how successful we can be with this. So thanks. Thanks, Shane.
Yeah, you're welcome. I was thrilled to hear it was actually virtual because our team locally really found the impact on us here and our clients. Kind of took away from the ILC, and I think having this virtual option, you can maintain and do both.
I was going to tease you and say, why did you leave La Clébèche?
Oh, yeah.
We should have an offline conversation.
Yeah, exactly. No, my husband was transferred, so.
Okay.
Yeah.
Thanks.
Hi, Shane. It's Connie from the Alberta Children's Hospital. I just have a question, and I apologize. I had to pop out for a second, so I apologize if you had addressed this. I'm just wondering if you could comment on what actual changes you made in your service delivery based on the data when you mentioned that you had actually demonstrated that the more frequent the therapy, the less satisfied or the less of change in quality of life your seniors experience. So did you actually change your service model then because of that?
Yeah, well, in Medicine Hat specifically, we were offering that full range anywhere from 3 to 5 days. So we've maintained that because there are some people who prefer the 5 days still. I know Lethbridge became a bit more lenient within their criteria. And so would take people who would require, you know, or accept only 3 days. So that was the change that we made.
So you're still making the decision for frequency of treatment based on the client preference versus the data versus the I'm just wondering.
Yeah, we felt that it was still to be client focused and family focused, that we left that to the discussion between the therapist and the client, because there were certain goals established from the COPM that actually do lead to quicker success if we saw them 5 days per week.
Okay.
So that's how we kept it despite the data.
Okay, thank you.
Mm-hmm.
Any other questions or comments for Shane? Shane, thanks so much. It's so great to hear from you 3 or 4 years later around your experience with the ILC. The other thing that I was thinking in my mind was similar to an amazing race is just that initial sense of confusion, and we're supposed to be going somewhere but we're not sure, and then how things, you know, with those prompts tend to become more clear, and you can get moving more quickly. So thank you. Thanks so much for your creative way of sharing your enthusiasm for the ILC process and the difference it's made for you and for your team. really appreciate that you talked about sharing and alliances really being like a fast forward, because that's very much the focus of our discussion today. And so appreciate that acknowledgement. And just really appreciate your time in being here. I know it's such a busy time, and so I'm sure Shane would be interested in any questions in follow-up. You could probably reach out to her, and for sure we'll have your. I refer back to your slides for examples. So thank you so much, Shane.
Thank you.
It's and you know what, Vanessa, we didn't really introduce you, and you guys, everybody's been hearing Vanessa in the background. Vanessa, please do this. Vanessa, is this taken care of? Vanessa is our senior project manager extraordinaire. She is so flexible and skilled and knowledgeable and creative, and we're so grateful for the way she's leading us through not just this day, but for the last more than a year working through this project and really making sure that we are at the point where we are right now. So I'm going to pass it to you, Vanessa, for a quick word before the break.
Oh, sure. Yeah, no, thanks so much, Julie. This obviously takes a village to raise a community PEAS ILC. So thanks to everyone for all your support. We are on time. And as a project manager, that makes me super happy. So I'm going to give you 10 minutes for a quick break. And the way that this is set up, the circle will turn turquoise, and you'll know that it's time to come back. And we'll just start right into our presentation after the break. Thanks, everyone.
Okay, so I guess it's 2:30. We'll get started back again. So glad you could get back. I just wanted to introduce the next section here. Melanie, the unit manager from Alberta Children's Hospital, Vanessa as senior project manager for the Pediatric Eating and Swallowing Project. We just wanted to welcome you back and hope that today's session has been informative and enlightening so far. Normally, if this was a full day session, we would have time to start working on balanced scorecards. However, given that we're doing this in a half-day format, we're actually going to tackle balanced scorecards at the next ILC meeting in the new year, because it takes a bit of time to dig into as per Shane's presentation and her example. So everything we've talked about so far is we can hit the ground running and do that at the next ILCs. So we're going to shift gears right now to work on your team charters, which are an important first step towards quality improvement and having a high performing team. A team charter has to do with how your team functions and communicates, collaborates, and also resolves conflict together. As Elaine mentioned at the outset of the project, there was 2 World Cafes in the northern and southern parts of Alberta in order to understand what was currently working and what was not working in the care of children with eating, feeding, and swallowing difficulties. Next to access to service and information, the second biggest barrier to high quality care for infants and children with pediatric feeding disorder was related to the lack of role clarity and collaborative practice. There are some examples from the World Cafe of the issues concerning families and care providers around role clarity and communication, including that understanding of who provides what service and that services occur sometimes in silos. Also trying to address that collaborative goal setting and sometimes that lack of multidisciplinary care. Some of the lack of role clarity can be attributed to the fact that pediatric eating, feeding, and swallowing is an area of practice requiring a wide range of skills and advanced training and mentorship beyond what is taught in our schooling. So when you think about the seemingly simple and yet very complex active eating, there are so many facets involved in motor coordination and safe eating, feeding, and swallowing. As well, the field is so vast that each of us can continue to grow in our professional development. So out of necessity and a desire to provide high quality care, healthcare professionals will often overlap in their roles when it comes to eating, feeding, and swallowing care. In addition, team composition and roles differ across the province depending on how the teams are structured, the client's needs, the disciplines that are available, and individual competencies. The result is variance in care for families, and there's a need for greater role clarity to facilitate a collaborative interprofessional approach. As part of the PEAS collaborative practice tools, there's a diagram that you see that addresses roles as shown here on the left, outlining the multiple and different care providers like the dietitian, OT, SLP, psychologist, physician, nurse practitioner, lactation consultants, and others, as well as the different training and skills, and the central role of the family, of course, right in the middle of that interdisciplinary care. You can see that the lines have been blurred and the colors are blurred to indicate there is often overlap between those roles. When we look at the triangle displayed, we've clarified that the individual scope of practice is determined by ministerial regulations, professional regulations, employer policy, and individual competence. As an aside, we just want to make a quick mention that this is all part of the roles descriptors and tasks within full scope package. It's available on the PEAS website under collaborative practice. We don't have time to cover this today, but just wanted to point out these tools as an opportunity for our teams to use along the way. We talk about these tools in the collaborative practice and roles webinar, and encourage everybody to take in the webinar if you haven't had a chance to do that yet. To you, Melanie.
Thanks, Tricia. So thanks for providing that background, Tricia. I guess the next question is, what does this all mean? Ultimately, it means that a team-based approach to care is required to best support safe feeding and swallowing, assessment, and care coordination. Dysphagia is a complex health issue. Feeding in general can be very complex. This was endorsed earlier by Elaine and Julie. It was demonstrated in Deanna's story and Nancy's sharings, and it's also supported by the evidence, including a pan-Canadian evidence review conducted in 2017. So the graphic on the next slide really illustrates the goals of the PEAS project with respect to building strong collaborative care teams and enhancing coordination of care and communication within the eating, feeding, and swallowing area of practice. The feedback from the PEAS World Cafes indicated a disjointed or a siloed current state, with teams separated by their discipline, by their geographical area, or even by their clinical program within the same site. So our goal is to provide teams with information and tools to help build care teams that are centered around the child and family and operating under a shared goal of best patient care, just like you'll see on the right side of this slide, with fluid communication between all members of the team, and to promote interprofessional care, bringing together the unique and critical perspectives of varied disciplines, regardless of whether people work in co-located teams or are geographically spread out. The concept of team can be varied. Across Alberta Health Services, teams have found that developing a team charter really facilitates ownership of collaborative working relationships in the care environment. It enables the team to function in an empowered manner and provides a link between the team's goals and AHS's overarching mission, vision, values, and goals. So Vanessa will just pop to the next slide. So team charter is a collaboratively developed description of the team members' responsibilities, accountabilities, and working relationships in the care environment. It defines the purpose of the team values, operating rules, accountabilities. It provides the scope and the approach to collaboration, outlines expectations, behaviors, and commitments. And it also provides an agreed upon process to resolve any interprofessional conflict that may arise. So happily in today's sessions, our teams get to go into breakout rooms to work on a team charter and focus on communication and collaboration. And then later we'll come back together to share some highlights with one another across the province. So exciting. At the end of today's session, each team will have a team charter that is close to completion, or at least far on its way, for you to share with your other team members, those who can't join us today, to validate and to strengthen it. We also want to emphasize that this will be a living document. Any team charter is. It should be revisited on a regular basis when new team members are orienting to the practice setting, or as your practice changes over time. And just a really key important point to get our mindset focused today. We often think of competency relating exclusively to clinical competence, and that is a key factor. And at the same time, it's critical to also acknowledge and focus on our collective interprofessional collaborative competence. In advance of today's session, we surveyed your teams to get a sense about what the top priorities are within each team based on the 6 competencies outlined in the National Interprofessional Competency Framework. So when you break into your groups, your facilitators will walk you through the process of creating a team charter, focusing on what matters most to you based on your initial feedback from that survey. Ideally, each team will walk through all 6 of those competencies, but even tackling the top 2 or 3 priorities is a great start and will be a springboard for communication and collaboration amongst your teams. Thanks. Over to you, Vanessa.
Awesome. Thanks so much. Thanks, Melanie. So I just wanted to, here, let me flip my screen around. I've got 3 screens. You should see it. It's like Star Trek over here. Okay, so as we go into our breakout rooms, some of the teams are going to meet together by zone. So for instance, Central Zone, North Zone, you have one big team. Others are going to be by site, and others are going to do this with multiple services together based on input from your managers. And yeah, so when you're working on your team charter, it's going to be one team charter for each one of those groups that you're in. We also wanted to just thank and acknowledge all of our amazing co-facilitators who are coming alongside us. They're from every corner of the province, and for the most part, we've just tried to pair you with someone who actually lives and works in your zone or in your area. And these fabulous facilitators come from a number of different teams and backgrounds, including health profession strategy and practice, COACT, quality improvement, project management, Path to Care and Alberta Referral Directory, Nutrition and Food Services, Knowledge Management, the Family Resource Center, and the Grand Prairie Public School Division. So just want to acknowledge them. You can kind of see who is all there. And I'll just mention to you in your participant package that we sent out in the calendar invitation, for the most part, we've been able to identify each of you and which team you're on. And so you can see that in the participant list. We'll also help navigate you there if you're not sure which team to be part of. So each team will also have an additional role. You'll need a reporter within each of your groups who can speak to 1 or 2 of these report out questions and then share them to the larger group at the end. And we did provide the report out questions to you in a package with a bit of a template as well, if you as a reporter want to use that to help you. So as we get started, we just wanted to share some ground rules. You can read them on the screen here and I won't go through all of them, but just wanted to highlight a few key points. So the process of creating a team charter has so much potential. It might feel a bit uncomfortable and perhaps vulnerable and a bit different, just being completely virtual. And we really hope that you can press into what matters, speak freely, and think collectively about how you want to function as a team, keeping the children and families at the heart of what you come up with. Your team charters are meant to be a living document, as Melanie mentioned, and so it's okay not to get it all done. The process of talking through your team charter is just as important as the document itself. We are learning together with you, and we'll probably fumble as facilitators when it comes to doing this in a virtual environment. So please just help us along, and thanks in advance for being adaptable. You can feel free to turn on your camera, especially in your small group. It might be really helpful just to see your body language. Sometimes that really just helps communicate with a thumbs up, smile, or nod. And we know that some groups are very large, so we just want to let you know we're going to do our best to give everyone an opportunity to share their ideas. And sometimes a facilitator might call on different people just to try to share the airtime, but you can also use the chat window to try to share some of your ideas too. We'll use a parking lot just to help us stay on track, whereby we'll just document any unanswered questions or things that might be out of scope for the topic today, but so that those ideas don't get lost and you can come back to them at a later date. So, and most of all, have fun, create together. We hope you're really proud of what you come up with and that you have joy in this. So I'm going to open up the breakout rooms, and what should happen for most of you.
Oh,
you're back.
We didn't want only about another hour.
I know, I felt like I was cracking the whip. Like, we're going.
That was just a teaser, wasn't it? Is everyone back, Vanessa? Do you know?
Yeah, everyone should be back now.
Welcome back. Thanks, you guys. So we are going to work through and have the reporters from each group give a little update and or a little reflection on the discussion, talking about one of the things on what you choose to speak to with this slide being a really prompt to move you forward. I'm just going to give you a heads up. We have 12 groups and 15 minutes, and it's the end of the day, so you do the math. I think if we aim for a minute and might sneak past a few seconds, that's great. So try to speak to something that's maybe different than you've heard from other teams as you go through the report out. I would encourage you to be specific or truly to try and make your example real, and know that everyone we'll send back the charters. So this is the amazing thing that Nora and Vanessa are able to arrange for us. As you're speaking, the values that you discussed will come up on the screen, so we appreciate that. And yeah, it looks like we're ready to go with the North Zone. Can I ask that the reporter just please introduce yourself and then dive into your report back?
Okay, Julie, well, it's Laurel Sheridan, and I am the reporter for the North Zone, and I'm an area manager in Grand Prairie. So as you can see, our biggest words were fun and accessibility and empowering, and we're very strongly agreed that we need this service to be accessible to everybody in the North Zone. I know we say this over and over again, but we're really spread out. We have a hard time making this accessible to everybody across the area, but I think everybody feels really strongly that we need to empower not only our clients, but ourselves to be able to deliver like the effective and the efficient service that they need. And then of course that we want to make this service available to everybody that we possibly can. So we came up with some really great ideas about how to do that and how to collaborate with each other. Thanks, and collaborate
Laura.
with our clients.
Thank you. All right, I think the Glen Rose Feeding and Swallowing Clinic is next. Sounds like a great discussion you had.
Hi, it's Cynthia from the Glen Rose, and I think for our next steps, I think we want to improve our collaborative practice within our zone and also within the province. And we also want to improve, advocate for our team, and continue to offer group education. And with all the technology, we can spread out that education and offer it to more people in the province with via Zoom.
We'll look forward to that. Thank you, Cynthia. The Stollery Aspiration Clinic, Digestive Clinic, Cleft Lip and Palate Clinic, and the Feeding and Swallowing Clinic all together is one big group. So not sure who's reporting for you.
Hi there, it's Amanda Adset from the Stollery. I work in the outpatient feeding and swallowing clinic. One of the challenges that we had in our breakout session is that we were trying to kind of find or speak very broadly with commonalities that were shared between all of our different clinics who all kind of do something a little bit different. So our discussion focused on, we probably do need to do a little bit more work in identifying each clinic's individual kind of mandate going forward. But one thing that was shared across all clinics was continuing to strengthen our relationships with the community, do some education about referrals, and sort of streamlining services going forward.
Thanks, Amanda. It sounds like you've got some next steps and some work ahead. You're thinking forward, so appreciate that. Thank you. Stollery Home Nutrition Program will be next. Who do we have reporting from the Stollery Home Nutrition Support Program?
That would be Jody. Jody, are you there?
Jody might be on mute. There you go. We can hear you now.
Okay, well, what I said was we have an amazing group. We had, sorry, I'm Jody. I'm the manager for the dietitians, the pediatric dietitians. And so I was stuck doing the report back here, but not what they're going to do it next time. They promised. So we had a great group. We had a variety of people in there that were newer to the program area and some that had been there for a while. And I guess the biggest aha moment we had was that the teams have participated in this type of process prior, and they quickly pulled out some of the old documents they had, and we saw how the evolution of mission statements and vision statements occurred. We saw that there were some misses, and I think the team is kind of, I guess, encouraged to look at those over again. They've also found some old documents on roles and responsibilities, and they committed to, over the next few weeks, taking those back and really updating their roles and responsibilities and having some further discussion. I would have to say the team did not disagree on anything. If anything, they really wanted to work on communication and wanting it to be really a team-based communication and everyone be respectful when they do that. So I think you can see that in that little diagram too.
Thanks.
Okay, that was done.
Great job. You guys are right on time with this. We're going to go to the Central Zone next. It's so inspiring and cool to see the different word clouds and how there's similarities, and each one has its still very much its own unique flavor. So nice.
Hi everyone, it's Christine Pizy. I'm one of the team leads and the practice lead for OT for Central Zone West, based in Red Deer. And I think communication also really stood out, and we're kind of uniquely situated geographically between Edmonton and Calgary. And so really talking about not only communication within our zone with our local zone partners, but also our partners outside of our zone. So that was a big one. And I think one of our first steps, because we are a zone team, is just sharing our Outlook calendars so that we can connect for future meetings to move forward on some of the work that we'll be doing.
What a great concrete step. Thanks, Christine. Excellent. So next, the ACH Home Enteral Nutrition Therapy Program, Eating, Feeding, and Swallowing Clinic, and Cleft Palate Clinic, and the Early Childhood Development Center. So another really broad group.
Really broad, yeah. And I'm just gonna, sorry, my name is Melanie Matisse-Ndur. I'm a unit manager here at ACH, having the privilege to work with a number of these team members and to collaborate with Mary O'Gorman, who oversees HENT. I'm just gonna reframe the name of our team as kind of the Alberta Children's Hospital Feeding Care Providers. We've brought several teams together here, and not that we had a difference, but we did identify a challenge in that we do have a lack of clarity of what is the range of services that are currently available, not only in the Calgary zone, but even here on our site, and how do they function, and how do we get from that state to what our ideal state is. So our aha moment is that we agreed that we do have responsibility to ensure that no matter what point on the continuum of care a child and family enters the system with feeding needs, they should get consistent service, they should get access to a full range of services. So how do we identify what has and has not been done for each child, and how do we get them access to the resources and care that they need? So that's the big job ahead of us, and our team just was so participative and collaborative in this discussion today. So thanks to everyone.
Thanks, Mel. Sounds like you are on the road. Okay, next is the ACH Complex Airway Clinic and the Calgary Pediatric Home Care Team.
Hi, that's
together.
me. I'm Jacinda. I'm the care manager for pediatric home care, community, and schools. So we really wanted to focus on a holistic approach to PEAS in order to provide more collaborative and coordinated care to families so that our delivery wasn't so siloed. We work in a multidisciplinary team and we have many people involved in feeding for children. We wanted to ensure we are being innovative, and one of our new items that we discussed in our meeting today is we're starting feeding rounds, which is new for our program, and virtually we meet every week. So we'll be starting a new meeting next Tuesday to start specific in relation to this.
Thanks, Jacinda. Interesting to see that innovative is one of the values that came really strong, and that you're already starting to talk about new ways to work. So really neat.
Thanks.
So next we have the ACH Neonatal Follow-Up Clinic.
Yeah, so I'm Kat Sprague. I'm the occupational therapist with the Neonatal Follow-Up Clinic. And so I think in terms of our team, it's a really established team where they've done a lot of work in terms of looking at values and team roles, and all of that was kind of pretty clearly laid out. But what kind of came up was having some people in our group from outside of our team, so from NICUs. And I think the idea of maybe our team being a bit siloed and kind of understanding how our team might collaborate in terms of more the bigger picture PEAS model and support for feeding, and maybe providing some additional support for the NICUs prior to them being discharged and kind of followed in our clinic.
That's awesome. Thanks, Kat. Sounds like you're on the way to some really good collaboration starting already. So nice. So the Calgary Zone Pediatric Community Rehabilitation Clinic is next.
I think that's me. I'm Catherine Bennett. I'm one of the care managers with Pediatric Community Rehab, and we're kind of in a rebuilding phase right now. Our program has really shifted from preschool and school age program to one kind of 0 to 5 with a focus on 0 to 5. So feeding, we have had some very small amounts of feeding services available. We're looking at what that looks like with a broader scope, and working with partners at Children's Hospital and Calgary Rural to sort of figure out what the continuum of care should be and where we fit within that. We kind of likened our situation, I guess, right now to all of this information coming at us. One of our team members said it's almost like a gourmet chef is teaching us how to cook, and the only ingredients we have right now are eggs and bread. So we're trying to figure out what it's all really going to look like when we get all the ingredients that we need as we finish through this rebuilding process. So thanks.
That's a great analogy, and yeah. I know that this full team is looking forward to supporting you guys in any way that you can, and just wish you all the best for sure. As
Thanks,
many on the line are going through really challenging times. So Calgary Zone Rural Allied Health is next. Christine.
That's me. My name is Christine Dendos. I'm the OT clinical lead and program facilitator for our rural program here. I think the family story that we heard at the very beginning of today's ILC meeting, I think that really was a driving force for us developing our vision and kind of just the vision that we see ourselves going. I would say that was a bit of an, potentially an aha moment in what drove us to, or started some of the conversation. We did great. I think we were agreeing on lots of things, and we seem to be all headed in the same direction, which is great. We're spread across 4 different sites, and so one of our key things that we want to focus on is that interprofessional collaboration. So just even though we're spread apart, having that good communication among our team to move forward with this PEAS project.
Thank you. Medicine Hat Regional Hospital. And I just really enjoyed being part of your discussion. So thanks to the Calgary Zone Rural Allied Health. Who do we have reporting from Medicine Hat?
So it's Janine. I'm the pediatric dietitian
at the hospital here, and I cover inpatients as well as our pediatric specialty clinic. So one of our aha moments was just that our group really wanted to work on understanding the roles of between the services within our area. So we have an understanding of our roles within our individual teams, but not necessarily between the different services in the area. And so Siobhan and I are going to connect, and we're going to work on setting up a meeting so that we can meet with the different programs and gain a better understanding of where we all fit in.
Thank you, Janine. Again, so cool to already hear some really concrete steps moving towards improving collaboration and coordination across teams. I'm sure if the families were here to hear this, they'd be much encouraged and grateful. So last, certainly not least, Southwestern Alberta Children's Eating, Feeding, and Swallowing.
That would be me. I'm Teresa Canu. I'm a speech language pathologist with Children's Allied Health in the South Zone in Lethbridge specifically. Our group, I think our biggest aha moment was that there are a lot of people in little old Lethbridge that we didn't know did feeding services. So that was kind of interesting. We know the people from our specific team, but not kind of outside of our group. So that's kind of one of our big things, is that we wanted, basically we kind of called it like a team resume. We want to know what everybody's expertise is, what it is that they do, and how their programs function. And then what we kind of said we'd like to do right away is probably come up with a little email group so that it's easy for us to kind of communicate, and then actually define or kind of come up with our resume so we all know what everyone is able to do and what they currently do within their role.
Great idea. Neat. Thanks, Teresa. Thanks, everyone, for your willingness to share. I really appreciate your active participation in developing the team charters, and really it's been so great not just to hear about this, but to experience and share in the experience with you. So thanks so much. Look forward to hearing your next steps and how things go in relation to building your team charter and building your team and overall quality improvement as you get into the balanced scorecards. As we wrap up, we wanted to give you a little bit of an overview to share a rough schedule of what's coming in relation to the ILCs and where you'll be working on your balanced scorecards and action plans, as Tracy outlined earlier today, and as Shane shared her story. These ILCs have been spaced about every 6 or 7 months apart, with an additional 1-hour education session in between that we will host and make available to all and to the public. Each ILC will build on previous workshop as you start working on your action plans and seeing your scorecards and improving over time. I think things will just more and more start to come together for you. We're planning to host the next ILC in February, and knowing that we are flexible and see what happens in our world and in our work lives. We'll send you a survey to vote for a date and time that works best for you right after today's meeting, with a plan to go forward in that way. One thing I just want to highlight that's not on here is that there is a clinical practice, speech language pathology grand rounds on this coming Wednesday, December 2nd at 8:15 to review the clinical practice guide. So if you haven't already attended, you'll want to attend in person versus looking online. If you don't have that meeting request, let me know. So broadly, next steps between now and February, we'll be sending you your team charters, and you can refine them and share them with your teammates more broadly. We know that some of you will require some flexibility, some extra time. There's lots going on for you, and absolutely the PEAS team will and leadership team will do all that we can to support you, and to know that if flexibility is required, it will absolutely be there. So members of the PEACE project team will be meeting with your team leaders to start working on baseline data collection, start pairing up your teams with a coach, and that coach will be working with you throughout the ILC process. So there'll be lots of great support to help you in your learning and move the team forward. Next slide. So I feel like we all just need to unmute. Would you guys please unmute, and let's give Vanessa and Nora a huge round of applause.
Yay.
I'm a little way to go, you guys.
Thank you.
Thank you. Nora is the administrative assistant extraordinaire, tech savvy, absolutely. And Vanessa, I said earlier, our project manager really makes us all look good and makes it look like this is so easy and smooth, because for her, it seems to be. She's got magic. So thank you to her. Of course, a really special thank you to Nancy and to Deanna, who I believe is no longer on the call, but absolutely they inspired us to move forward today. Thanks to Elaine, thanks to Tracy Wassilik, always for her knowledge and experience and willingness to share. Thanks to Shane for your great example and just walking us through the process in a way that can make it real. Thanks, Melanie, Trisha, for your work around the implementation, the ILC, the collaborative goal setting. You've done just a ton of work in co-leading working groups and pulling this day together along with Vanessa. Thanks to our many facilitators and scribes, the PEACE team, all of you. Just thank you. Little heart-shaped
and
bowl
it
of
was
peas goes out to every one of you.
It was my miss to not put Gloria. Your name is in here. I know you're one of our facilitators, but she has been like a right-hand person for me. So I would be remiss not to say that. Thanks,
Thank
Julie.
you, Vanessa. In fact, earlier there's a little bit of a cheer when the facilitators got together and saw Gloria. So yeah, absolutely. We really hope this time has been valuable for everyone, and that your teams have been able to become familiar with the ILC process, with developing a team charter, and even more importantly, with it to help to think about how you might continue to grow as a team and work forward. So please share your feedback with us. There will be a brief survey that will pop up when you close your Zoom window. You can also, of course, feel free to reach out anytime. There is using the PEACE email. I think it's just, what is it, PEACE@ahs.ca?
Yeah, here, I'll write it in there. Sorry, I missed that.
You're writing it. My chat box isn't open.
There you
Yeah.
go.
Oh, peas.project@ahs.ca. Peas.project@ahs.ca.
Hey, Julie, just
Thank
a really
you very
quick,
much.
Julie, really quick question. For those people who weren't able to attend today, you said that the session was recorded. How can we get access to the recording?
I will post it on the PEACE website.
Perfect. Thank you, Vanessa.
For sure.
Right. Yeah. Any other last questions? Feel free to pop them in. If not, thank you. Have a really nice evening. Good break. I know that your brains are full. Vanessa once again hooks us up to the fire hose. That's her favorite phrase. I think, yes. Vanessa, you are a fire hose. That's what I.
You guys are amazing. Thanks.
Thanks, guys. Bye for now. Nice to see so many familiar faces.
Bye. Thanks, guys.